welcome back to our session. I need to go back out where the snacks are, or we can move the session to the snacks. I'm not sure what's going to happen there. We kind of got lost in this room. Maybe people will hear my voice and it'll be a calling that they'll join us. So this is our last panel of the day. However, it's not our it's our final session of the day, if you will, so we have one other after that follows this. Our next session here is data analytics and cancer stage shifting. The ability to collect, analyze large data sets provides an unprecedented opportunity to understand the mechanics of different cancers. How can we use this knowledge to shift more cancer diagnoses from late stage to early stage? Please join me in welcoming our panelist and moderator to the stage. Our moderator is John McDunn. Hey, I'm sorry, I just screwed that up. Back one. Our moderator is John McDunn, PhD, President of Project DataSphere. Kayla Emeru, Vice President, Health Information Strategy and Services with the National Minority Quality Forum. Scott Morris, Vice President and General Manager, Clinical Trial Solutions, Optum Life Sciences. Maya Said, Founder and CEO of Outcomes for Me, also a new CEO Roundtable member, so thank you, Maya.
Thank you.
And Mark Shapiro, Chief Operating Officer of XCures. Panelists, we gladly hear you.
Well, thanks, Mary Liz. And one thing I learned in graduate school is you always thank everyone first before you get into the talk, because sometimes you forget. So I really want to sincerely thank all of you for being here, staying with us through this long day of amazing content, and to thank the panelists here for their collaboration and partnership over the last few years and going into the future. I'm really excited to see what we can do together. I was listening to Dr. Martinez-Lopez earlier today, and he said something that I think we all know, but it's easy to lose sight of because we get into the detail of the work that we're doing, and we get focused with the tools that we're using. But you know, what he said really stuck with me, and I want to recenter us, and it was our mission is about serving people, right? We use data and analytics in the service of finding better ways to take care of people. You know, and so the data that we work with, the tools that we use are amazing. These are things that were not possible, you know, even maybe a decade ago. And so I'd love to invite Kayla and Scott to both talk to us about the data sets that they use and what analyses have informed kind of their approach and thinking around where we are with oncology and how they're leveraging digital transformation to reduce barriers to accessing innovative cancer care, especially in communities that are medically underserved. So, Kayla?
Sure. Thanks for having me. Glad to be here on this panel. My name is Kayla Emeru, and I'm the Vice President for Center for Health Information Strategy and Services with the National Minority Quality Forum. We had Dr. Parker in on the last session, so I believe you got a chance to hear about some of the things that we're doing with NMQF and our cancer stage shifting initiative. But the organization has been around for 20 plus years, and it's been collecting data for that long, and we have over 5 billion patient records, over 100,000 conditions. So it's had the foresight to start collecting data since about 1998, and we use that data to inform our initiatives and at the community level to integrate and design some of these solutions that we were talking about earlier and what's needed. So our vision is really to create that just and fair healthcare system. And there is no way to do that without really being patient focused and reducing patient risk. So if you're talking about reducing patient risk, it all boils down back to the data. So data quality is important. And we use various forms of data. We have claims data that we focus on. It comes from CMS, Medicare, Medicaid. We now layer social drivers of health data. I know that was a big topic, and that's what so for the purpose of the Cancer Stage Shifting Initiative, we are trying to build a model in which we put all this data together, not only the air quality education, income inequality, food insecurity, have all the data together and apply machine learning, AI that you heard about and seen some examples from SAS earlier to really get some really good output on where the patients are, how can we intervene, how can we make it specific. So that's some of the work that we're working on.
Yeah, well, that's wonderful. And Scott, I know you have a kind of another lens into communities and kind of the scope and scale of data that you work with at Optum. We'd love to learn a little bit more about that and how that informs your thinking.
Sure. So Scott Morris, lead our clinical trial solution group within Optum Life Sciences. And what that really means is I'm serving both internal customers at Optum who may be involved in running clinical trials, and we're providing some enablement capabilities. But also, we've got a research network that we support, and we do a lot of work in the life sciences space. So we're sort of an in-between because we sit in the middle of healthcare. So I probably should back up a little bit with, first of all, welcome everybody. I'm local, you can tell. Just live on the other side of the county, although I think I got here later than some people who flew across the country due to traffic and me misjudging how long it takes to get across Wake County these days this morning. But welcome. I noticed you had sweet tea in the cafeteria, so feels like home. I do travel all over the place, but it's good to be in North Carolina for the end of this week. I also will say, based on earlier conversation, particularly around the ACE cohort, where Gary was involved and others, I mean, solving representation in clinical trials is a moral imperative. It's a health equity matter, can and should be solved. And I'm glad that it's a key part of the discussion that we're having here. Data is an informer, but the actions related to what the data tells us is really where it happens. And I know this firsthand growing up in the state just south of here. It has a high minority population, and having people that I've worked closely with over the years who have been in medical practices serving very underserved parts of that state. And it can be, I've seen it work, where patients can get involved in trials, who are seen in the community, who are informed about those trials from their treating trusted provider who brought the trial to the community. Didn't say, go to Charleston to the Medical University of South Carolina, 2 hours away. Let's do it right here in Sumter County, right? So I wanted to make a plug about that. But we think about why Optum, why are we here, and what's our lens into the data world and healthcare. First of all, we're part of United Health Group, and you were talking about our mission to serve patients. I mean, the core mission of United Health Group is helping people have better lives and helping the health system work better for everyone. And that's a big, tall order, considering the various pieces that we touch in healthcare, from being an insurer of commercial lives, being a Medicare Advantage plan, of having within United Health Care, even Medicaid programs that we support. So, government, employers, but at the end of the day, it's people that we serve in both the United Health Care, which is the health plan, and everything else in United Health Group that's not in there is in Optum. And Optum Health now has become the largest healthcare provider in the U.S. that we have 130,000 either physicians or highly credentialed practitioners in Optum Health. They see about 45 million patients, and we're trying as hard as we can go to increase access to clinical trials to those patients that are served in Optum Health. So that's one platform where there's data. Another is a number of health systems that participate with us that provide clinical information for us, and they're either part of our research network or we're providing analytics back to them for performance improvement. So we're working both across claims information that we may see, but also the electronic health record data that we use, and it's about 115 million patients. So I'll throw out a lot of numbers. United Healthcare, and I have one of my colleagues here, our chief medical officer who for oncology and genomics is here. She actually was one of those that flew across the country, probably got here before me. Dr. Langer's here, and some of you will see her later on at dinner and so forth. But United Healthcare is serving about 53 million, give or take, across those different platforms. And then, as I mentioned earlier, Optum Health and our healthcare delivery platform is serving about 45 million. And then outside of all of that, many other health systems participating with us. So in our life sciences group, we sort of cut across our Rx business. Many of you guys may have a PBM card that says Optum on it. You might have an HSA card that says Optum on it. But we're cutting across both the health, the Rx, and the insight business to do the work that we do on behalf of serving the research community and life sciences that I'm involved in with our life sciences and clinical trial enablement capabilities. So that data is used for the purpose of protocol modeling. It's used for the purpose of epidemiological studies, outcome studies. We're using it for matching patients to trials. Any possible way that we can improve health conditions, we're leveraging that information. So.
Well, that's really great to hear and to understand kind of these large population level data assets and how they can be brought into community. You know, we keep kind of thinking through this problem of how do we deliver solutions into community and what does it take. And we heard in the Going for Gold forum this morning, many of the schools, as they were kind of going through their testimonials about how it's building and sustaining trust in those communities. And you know, I think an interesting thing is how do we use technology to do that, to enable patients to become their own best advocate and to then get into a navigation scenario or a system that may help them, you know, find the best possible care. And so I think you know, some of the tools that Maya's team and Mark's team are building are really thinking about that. And I'd love to just maybe they can share some of their work as well, and we can think about how when we take these large data sets and go down to the personal, how does this meet in the middle and deliver really high quality care to as many people as possible. But Maya, go ahead.
Yeah, no, thank you. And so I'm Maya Saeed. As I was mentioned, we're new. Outcomes for me is new to the CEO Roundtable. This is the first meeting. I'm personally not new to the CEO Roundtable, having spent my entire career until starting Outcomes for Me 5 years ago in the pharmaceutical industry. Most recently at Novartis, leading global market access and in oncology. But the reason I started the company 5 years ago, 6 years ago, was I had my own cancer scare. It was just a scare, quote unquote. But it was an ordeal where I had to go for a second opinion, do open surgery, a 6-month ordeal. And that's when I realized that for 20 years in my career, I thought I was patient-focused until I realized I had no clue what a patient is. Because I had never been one until that moment, and it was only a 6-month episode. I'm not your average patient. I'm a scientist by training. I worked in the industry. I had a very good health insurance. I knew what my rights were. And, you know, I had to call NYU when I had, you know, the initial imaging saying I need the images because I'm going to Mass General to get a second opinion. They said, go online, it takes 30 days. I said, no, I'm showing up this afternoon, it's my right. They gave me a CD-ROM only to show up at Mass General saying they do their own images. And of course, not covered by insurance. So to say the least. So that's what led me personally to start the company. Our mission and commitment, it is a long journey, is to democratize cancer care by empowering patients to get the best possible treatment and achieve the best possible outcomes given the latest science at that moment and their personal preferences. And both are important, and this is where I'll come to the data piece. I think in the previous comment, and thank you also for your comments from a patient perspective, at the end, when somebody's diagnosed with cancer, we all know it, it's very personal. The needs are personal, the context is personal, the preferences are personal. The science is around us, but that's only one input into the data that really could ultimately get that person to take a more proactive approach to their care and to help them get access to the best care and resources. So that's the problem that we are trying to solve. The way we go about it, as John mentioned, it's using technology. So we try to reach as many people as we can by actually using the power of technology. What that means is our main product, quote unquote, which is free to patients, is a personalized, it's an app. Now, with the understanding that there's also, I'm part of another effort that's called Tequity. How do you ensure that people have access to technology? But it's really providing personalized evidence-based navigation. So what that means is, we try to better understand what the clinical diagnosis is, but also what the personal preferences are, and the context of the patient, and to use that data to help them know, first of all, what their options are. And options include clinical trials, but clinical trials is only one component of care. And for many, we actually help make them understand, if it's relevant to them, why considering a clinical trial may be at that moment the best treatment option for them. But also connect them to local resources. So what we invest in is the technology, and for everything else we partner. So what that means is partnering with local groups, with large organizations. We have partnership with the NCCN on the guidelines. But to really bring to bear all that content, all that information, and personalize it at the level of the patient, and have them access both broad resources, but also localized resources. I'll say just a couple more things. Obviously, the reason why technology has not solved our problem in healthcare is probably not because of technology. It's especially when it comes to patients. I always joke that, with anything else with our lives, technology, as people first, technology has solved a lot of our needs. But in healthcare, we're back 20, 30 years ago in terms of how we as people interact with technology when it comes to our care, as consumers first. And one of the challenges of navigation, as we all know, including the Cancer Moonshot is starting to address this, is who's going to pay for all this, right? And the problem is, if you do anything that's charging the patient, that's dead on arrival, right? Like, that's not going to work. Now, us coming from a pharmaceutical background, and this was said in earlier panels, we feel like there's a win-win here. So our business model is focused on actually working with the life sciences industry. And it's really working with the life sciences industry around one of three things: clinical trial recruitment, accelerating recruitment for clinical trials, and getting diversity in clinical trials, and also understanding why people do not end up on clinical trials. A lot of times it's just because, you've mentioned it, it's just because, people are not willing or cannot travel 10 miles, 5 miles during they have work. They can't just leave their work so even understanding this and surfacing that data could ultimately, lead to some sponsor changes or designs of some of the trials. The other is around the data itself, understanding whether people are being tested, if they're getting tested, and we'll come back to the cancer stage shifting topic. And then the last pillar is around getting people the information they need around the treatments options that they have, and once on treatments, how to keep them on treatment and give them access to whatever support services around them. So I'll pause here.
Thank you, Maya. So I'm Mark Shapiro. I'm the Chief Operating Officer at XCures. We had, I think, maybe a similar origin story, and I think it highlights probably the fact that once you have cancer as a patient, no matter how much you know about this business, the healthcare system here in this country does not do a great job. Now, sometimes it does a great job, and sometimes it does a terrible job. And we've worked with patients who are extremely wealthy, who do not get great cancer care sometimes, or not without certain advocacy. We've seen good hospitals do bad things. So when we set out, our founder was internet entrepreneur, very wealthy guy, metastatic cancer survivor, a man who actually funded a biotech company so that he could get in their clinical trial, and did well, amazingly. So, and of course, he was always fixated on why did that company fail, because although that early generation cancer vaccine worked for him, it did not work for enough people for it to be commercially viable. So that was, 20 some years ago. He created a nonprofit where he hired a bunch of PhD cancer biologists who would sit down with patients and advise them about clinical trials. Very expensive, not a very scalable model, and they worked for free for probably about 10,000 patients over several years, trying to find what was the right trial for you. And I think this was a really interesting question beyond just can you get into clinical trials, but if you can, are some better than others? And when we set out, we thought this was a really interesting question, right? Could patients kind of crowdsource information about what was working for them and share that so that they could kind of help steer themselves towards the trials that seemed to be successful? This is a really difficult, complicated problem. So being software developers, we built a platform and trained an AI model, which we took to the FDA as software as a medical device in 2020. What we did was, with these hundreds of initial patients, we collected their medical records. We trained a model on clinical trials, case reports, drug-gene interaction databases, really kind of all the background information we could find back then. And then we started running molecular tumor boards. We'd present these cases, and we turned it into a recommender system, kind of what we were calling Netflix for cancer, kind of tongue-in-cheek at the time. That's how it worked, right? Tumor boards like things, they rank them higher, they end up going up in the algorithm, and the algorithm just keeps learning. What we discovered in that process was that quickly the algorithm was better than the tumor boards, and the FDA at the time was certainly not prepared to try and regulate anything like that. So there wasn't really a commercial path forward, but we ended up focused on probably the much harder problem at the time, which was getting the medical records to put into the algorithm in the first place was way harder. And so we worked directly with thousands of patients, but now our software is designed to collect, organize, and structure medical records. It takes about 15 minutes. We can get records from anywhere in the country. We put them all into a common data model where they could go into other companies' decision support. And there's a bunch of companies we work with who have algorithms. It's being used by telehealth companies, patient assistance programs. So the software itself kind of solved a problem that we had for other people. And on the back end of all of this, we continuously run a patient outcomes registry. So we've got about 150,000 people. It's a very representative sample, across the country. We probably see data for each patient, about 30 different practices and facilities, about 1,400 records in total. So it's a vast amount of data on each. And we're, I think, trying to solve the data liquidity problem, which to do anything in healthcare in this country, the data is incredibly fragmented. Trying to even figure out real outcomes is hard. Patients move around. When he was talking about the Nordics, right, these other countries have it, I think, much better, right? Their systems are a lot more organized and cohesive. Here, if you're a cancer patient, you end up carrying binders of paper around, or, I took my father up from Duke to Johns Hopkins at one point for a consult, brought all the records, brought a bunch of discs, and, after 2 days, they're like, well, there's one image that we're missing, right? So we flew back, we couldn't do his surgery, flew back to get that image. Duke didn't want to do the image, and then the pandemic happened. He never got the surgery. So this kind of, when you're a caregiver for a cancer patient or a cancer patient, it's like a full-time job, on top of a full-time job. So, I guess that isn't even really why we're here today. We're here to talk about analytics and cancer stage shifting. So I did actually ask my team to try and come up with some real data to share with this group on what we could say about cancer stage shifting in our data. So we looked at 12,000 breast cancer patients. Like I said, it's a representative sample across the country going back to 2018, just to see how, the staging at diagnosis had changed over time, and, probably tell everybody here what they expect to hear, which is that, race matters, right? That's very evident in our data. African American patients are diagnosed at a later stage, and that's consistent. Hispanics are diagnosed at a later stage. And, I think when we think about data and what you can do, we've got to start measuring this stuff, right? And you got to get out there and tell people this, because I think at times maybe there's a fear to say, like, there are still inequities in the healthcare system, but if you measure them, right, we're all data people up here, the data is telling us something.
Well, thanks. I think that's a really good point to kind of build from. We can use these data assets to establish metrics. We can start to understand where there are the kind of most egregious discrepancies or inequities by looking at some of these metrics across communities. And then we can design and measure the effective interventions, right? These data provide a really meaningful starting point for going into the future, but it's only possible if we communicate those well and work together, because I think each person up on the stage has a different lens into a part of the problem, right? Everyone in the audience has a different lens into a part of the problem, and when we come together as a community like this, we can start to think about, if you put these 3 or 4 pieces, these half dozen pieces, all of these pieces together, we can do something that no 1 or 2 of us could do individually or with our own organization. So I think it would be great to just kind of get a perspective of, where is there a substantial barrier to progress? Or if we were to remove a barrier to progress, where could we be in 12 months or 18 months from now? Maya, you want to go ahead?
Yeah, I'm going to share. So I'm going to look at it because a couple data points actually where, at least just to get at your question from an angle. I don't know if it's a different angle. But we started, Outcomes for Me started 2 years ago, what we call a patient empowerment report. Now, it's very ambitious because, I go from a place where it's better to start small and grow as opposed to kind of try to perfect something and never actually put it out there. So, but the idea behind it was to say, you cannot manage what you don't measure. Yeah. And therefore, we wanted to put forward, start a dialogue around what does patient empowerment means, and how do you measure it, and how can you measure if we made progress against it. That's just the premise. And so we started we did now 2 of them, last year and the year before, but we had essentially a framework, and I'm just going to give you a couple data points from that, where we surveyed, in that context, it happened to be breast cancer patients across the country. The first report had 2,000 patients that were surveyed. But I'm going to give you data points on both clinical trials and on genetic testing, and I'm going to start on genetic testing because that's actually impacts cancer stage shifting. On that report, again, it's a survey self-reported from patients. 37% of patients were not recommended genetic testing or genomic profiling at diagnosis. We're talking about breast cancer patients, which, as per the guidelines, everybody should at this stage. 26%, a quarter of the people that are recommended genetic testing have not been tested. And then there's disparities. So those numbers change. And to the question, did your doctor recommend genetic testing or genomic profiling of your tumor? If people were in urban or rural setting, that number was between 44% and 50% versus a suburban setting, which was 83%. And this is the doctor recommending, not the patient asking for it. Based on income, 50% of less than 75,000 annual household income, as opposed to 88% of over 150,000 household income. And then on race, 63% of white versus 59% of non-white. But that's, so to go back to at least on one dimension, there are, and I mean, like this has been documented elsewhere, there are, if we're going to do cancer stage shifting, at least in the context where we operate in, which it happens to be also somebody that has been diagnosed or is at high risk of cancer, one actually, in some sense, not that costly on the system is actually to get testing out there to everybody. Yeah. And today, even doctors are not recommending the testing. Now, if you unpack that, it's multi-dimensional. There are perception of whether there's gonna be a cost associated with it. There's perception, is it covered by insurance? Mm-hmm. The problem is these things change all the time and very quickly. But the thing that I think we can change tomorrow is it should not prevent a doctor from actually requesting or asking about the test. And also, and this is where our mission is also helping patients be aware, people being aware of the importance of the tests. And also, most of the time it is covered by insurance. So that's just one example.
Yeah, I think that is a super important point. Yeah. And it's, to run a tumor board, right, if you don't have molecular profiling, there's not a whole lot to do. This is the, I think, most important educational thing for patients to understand, to advocate, is to get that molecular testing up front. Those genomic labs do have patient assistance programs, and we see it too in our data, right? Especially certain tumor types, people don't think there's anything to do, so they don't order it, right? And then you lose that information, you lose the access to clinical trials, right? Because the trials today are so heavily driven by molecular profiling. So anybody who didn't get it, right, they're being shut out initially. So if you know anybody, right, this is super important and you should advocate for it. We actually partnered with a company called Genome Medical, which is a telehealth genetics counseling service. They will order it for you. So you can sign up, at our website, they will order it. But we feel very strongly, we're not affiliated with any of these labs. We are agnostic on lab, but this is super important to open up options for yourself in the future, right? And hopefully your cancer treatment earlier goes well. You don't need it, but you don't want to be at the point where you don't have that tissue available for sequencing.
Yeah, go ahead. Let me just add to that, because I think, Mark shared some data as well as Maya. I think the data has been telling us something for decades now. As you mentioned, NCI and others have pointed out, we know where the worst rates for mortality of cancer, whether it's combined or some of the top cancers are. We know which communities are struggling. On the other side of that, you have now innovative therapies that are available that are not reaching the most needy. Yeah. So I think what we are to do is, which is why the Cancer Stage Shifting Initiative was put together, is how do we come together in a way we put integrated solutions from companies that already have the products out there and softwares out there that can solve the problems for this population that are disproportionately being impacted. As far as who pays for it, we're already paying for it. The healthcare industry is $4.5 trillion. That would be the third or fourth largest economy in the world. So we're already paying for it, and what we're saying is, we could take care of people and probably have it cost less, and offer the most innovative and breakthrough therapies that are available. And it's a win-win for everyone. The more patients you bring into the patient pool, the patient gets better, the health system wins, the therapies that are available are used. And that's what essentially we're trying to do.
It's interesting that the data can inform, but it doesn't close the loop on the action, right? So a patient can be flagged that they meet the qualifications for low-dose CT scan because of lung cancer risk, because of whatever the calculation is, age, 20-pack year calculation, I think is now, 45 or whatever it is. Yeah. And so, but then it's closing the loop on the action, and that happens on the ground, in the community, at the practice, or you know, mobile CT scans in parking lots at the Walmart to get people to come in and get that done. But yet the data can highlight where the gaps are. There's still action that has to be taken to close that loop.
And I really like that we got to this point about talking about we've got the data, now it's time for action. Part of that action is Q&A. So we're going to go to the audience and let y'all query our panelists here. In the back first? Okay, perfect. We'll come around. We've got. Thank you.
Hi. Hello. My name is Marcelo. I'm from J&J, but this is a non-J&J question. So, you know, I'm a hospitalist as well as doing a lot of public health stuff. And one of the success stories, I think, for how we interact with a very common problem is urine testing, right? So when I order a UA, I don't have to decide whether or not that urine gets cultured. Behind the scenes, an algorithm smarter than me decides to put on the culture or not put on the culture based on what initially comes up. And I also don't have to order resistance patterns if the urine comes out contaminated. All of that thinking has been removed from my head. I can think about other stuff. And I think the care or the detection of urinary tract infections in the inpatient setting is dramatically improved by removing the doctor's decision from things that should happen a certain way. So when I hear something like this should be ordered, you shouldn't have to get someone to think about it. If we model it the way that ERs order urine cultures and sensitivities, that we already have models of how to take thinking out of people who are really busy trying to do other stuff. On the other hand, we're not supposed to order urine tests on asymptomatic patients walking in for a physical exam. Right? There's clear data that shows that getting urine on a yearly exam for someone who's asymptomatic has no value. So something simple, getting a urine test, is pretty well worked out. Here's an example where you shouldn't do it. Here's an example where it's done automatically for you without thinking. So I think there are existing models of how to decouple some of the decision that isn't happening and make it a lot smoother. So, thank you.
Yeah, I think that's an excellent point, especially because, as you said it, like take breast cancer as an example, right? Where now genomic profiling was not historically because there were no approved drugs that actually required the genomic profiling, or now that has changed, but that's very recent. That's in the last couple of years, and so, but for it to actually really be disseminated across the country, it's going to take another 5-6 years, even more, if it's not very quote unquote regimented, automatic, given the change, right? So
yeah, we've tracked and seen like a big increase in next-gen sequencing for brain tumors, and there are no targeted therapies because all the therapies are terrible. But what we've seen is eventually, there's a lot of off-label practice now as people are sequencing those tumors and using off-label therapies, sometimes to good effect. But I think cancer is very complicated. Super, super complicated, right? This is why we thought initially you need decision support algorithms, like you need AI, because the community oncologist is confronted with just, so much information. It's hard to stay current. If you're a specialist at a specialty center and you see one type of cancer, you probably know all the stuff, right? But if you're a generalist and you see like 2 glioblastomas a year, you may not know the stuff. And I think that's where it becomes difficult. That's why, we encourage people to advocate, but I think there's an enormous role for clinical decision support, you could say AI, but decision support in general in cancer.
Mark, I think community oncologists on the front lines represent the latter, which is they only see 1 or 2 of this and that every year versus the specialists at the academic center and the research center. But the patients are being seen out in the community.
Yeah.
All right. Seen a couple hands. Is there a microphone with somebody?
Yeah, I do have a question. I'm just curious, with all new technologies, you can use them rampantly like anything else. Given the nature of cancer and that there are genetic and major epigenetic factors, timing of screening, can you give me some insights into who should be screened, when, and is a one-time live screen, or do I do serial screening and frequency? I'm just curious.
Fair question.
Oh, that's
It's the MD of the panel.
Loaded question. Jump ball. Yes.
yeah. I mean, right? There's public health service guidelines, but these are changing, and it's. I think if you're a patient who advocates for yourself, right?
You're going to get
You need to make the time to go in and do the screenings, and it's serial screenings. I think one of the scariest trends that we've seen, and a lot of people have been trying to figure out is, why are we seeing so many people around age 40 with stage 4 colorectal cancer? I mean, this used to be something that was diagnosed in older people, and there's this, I mean, not totally puzzling trend. I think ASCO GI this year we saw some insights, but this is a scary thing, right? And these are people who are, before the age where they'd be recommended to get colonoscopy. So, I think we do need to think about screening. It's an important piece.
Yeah, and I think a lot has been mentioned in the earlier sessions as well. I mean, again, if you know the prevalence where you live is and where air pollution, the environment is high, we know if your mortality in that area or if for your specific race and ethnicity is higher, these are patients that should be screened. Unfortunate fact is the patients who need to be screened are far from it. And so there needs to be guideline. There needs to be specific guidelines that are tailored based on person's age. And I think that's where the technology is headed. So that if we empower the patient with their own medical records and we apply AI to it, now it becomes a shared decision making. Not only is the patient aware of what's out there, but then they're guided by the AI for their specific condition.
Hi, I'm Divya. I'm the Chief Growth Officer for Cure AI. So my question is clearly going to be biased. I was triggered a little bit by the comment on the need for a clinical decision support system or better AI at the point of diagnosis. The technology exists for a lot of different clinical domains, and it's definitely rapidly developing. But as an AI vendor, and my question is more for the US healthcare system, we have not only data silos, we have payment silos. So an AI vendor is trying to convince a diagnostic department like radiology, for example, hey, you should buy this AI because it will help a patient get diagnosed early, which will improve treatment outcomes. But the radiology department doesn't care because they care for efficiency. So I'm trying to actually understand that how do we break this? At the end of the day, there is a win-win-win, right? The patient can get diagnosed faster. The overall healthcare spend can get reduced. And the cost of the technology is actually rounding error in all of this, frankly. But how do we break this payment cycle? How do we break the data cycle, I think, is a much harder question in terms of fragmentation. But how do we break the payment fragmentation?
Wow. I feel like we've got a better chance. Oh, go ahead.
Ask a follow-up.
I was going to say that's
on this point, because I think it'll broaden the discussion. This is Greg Goldmacher from Merck.
Incentives, by the way, right? So what are colonoscopy? When you go to the colonoscopy suite, what is that whole team in that colonoscopy suite set up to do? Do colonoscopies. What happens when there's a blood biomarker that comes out that is highly predictive, maybe multiple better than the current Cologuard, standard? Then what happens? What are the people in the colonoscopy suite where the reimbursements come from doing those over and over all day long? If it's displaced with a breakthrough that's highly predictive, so
just
incentives.
To add to this, and this is about incentives really, and who has them and who doesn't. So there's an opportunity with AI to develop sort of opportunistic screening technologies, right? People come through the ER, they get CT scans for abdominal pain, right? If somebody, I'm a radiologist by training, I know, when I'm looking at a scan, I may miss subtle early things if I'm not primed to look for them. So there's a possibility of developing AI tools that will find those things more reliably. The problem is, and I've tried to push for this, within kind of from a pharma perspective, but who's going to pay for it? Because insurance companies don't want to, because patients change insurance every 18 months, right? Which means no individual company benefits from saving the cost that will come 3 years later, even though it's a dramatic savings for the system as a whole, but they're not going to capture that value. So if everybody could coordinate and do it at once, everybody would benefit, right? But there's sort of a first mover problem or a coordination problem. No individual, it's sort of a, kind of a bad Nash equilibrium. Nobody has an individual incentive to change strategies. So how can we do this collectively?
Well, I was going to say, I think solving the data problem in U.S. healthcare is super hard, right? Yeah. We all agree. I think that's an easier problem than the, financial flows. I think that one is, just a next level. Where I think these new technologies, and we've seen a little bit of success, is really just consumer driven. That, hospitals put this on their website that they have this new thing, and patients respond, right? Patients ask for it. I mean, that's a tough way to change healthcare, but I think, we do see patients are a little bit more open to advocating for themselves now, and I think that was kind of our message, right? If you're a patient, you have to advocate for yourself. It's, cultural and generational, but, we all need to start learning to do this in the healthcare system because, frankly, in cancer, like the oncologists are the busiest people I know, and, they get you for 15 minutes and then they have to think about the next person. There's no air traffic control. They're not thinking about you when you're not in the room, so you need to go in ready, set, advocating for yourself, or if you're lucky, have somebody who can do that for you, because when you have cancer, you feel really terrible and it's hard to advocate for yourself. So, people who have an advocate with them, I mean, that's, now you're talking about 2 people missing work to go into those appointments, which, you end up waiting all day sometimes. I mean, this is, so what happens, but, that's how you get the best care.
But I think, if you take the payment issue, that is a big issue. I think in cancer, in some sense, CMS should be doing more, right? Because, the insurance will follow, right? If they come really more forward around, dealing, because, it is the insurer that can probably has most to gain, if you will, from things like this, right? And then, even now this year with the CPT codes on navigation, right? They're trying to push that. Let's see where that goes. But in some sense, you can have as much as and this is all we do, right? Like the patient could advocate for themselves, but at the end, if it's not reimbursed, it's not, right? So in some sense, we still have to solve that problem.
And before the patient can even advocate for themselves, this goes back to the earlier session of what was being discussed here. The health literacy need to be there,
Yes.
that trust of the patient and needs to be there with the provider. And the way to do that, the way to build that trust and credibility is by being in the community. And there was discussion about training and actually educating and hiring, especially in the context of clinical trial diversity. So this is not something that you helicopter in and do. This is something that needs to be there in a long-term fashion.
Not a quick fix. Yeah.
Yes, it's not a quick fix.
All right, I think we've got time for one more question. So, yeah, please.
And so I'm looking at the title here, stage shifting. And so I thought that was very interesting. I think we have to think about that healthcare for cancer is simply not the same in every state in the United States, in particular the South. We got a problem. Every community is not the same. I live in Tennessee and have 95 counties. 78 of those counties are rural counties. And let me tell you, they have disappearing healthcare infrastructure. Not enough PCPs to handle the people with whatever they have. And so that has to change in some way. I want to talk about something Dr. Shapiro talked about, and that is one of the barriers that has not been talked about very much today is the barrier at clinical barriers for things like breast cancer. We think about breast cancer. Over the years, decades, Black women have been diagnosed later. They have had long extended periods before their cancer was staged. And many times when they got treatment, the treatment was not what it should have been. And so these are women that are coming in possibly with early diagnosis, but because of the wait and because of the treatments, this could be people that will turn up with metastatic disease at clinical presentation. And so that has to stop. When you're looking for cancer care, insurance is the foundation of getting that care. And the idea, what happens to those people that are underinsured or uninsured? Turns out, if you're uninsured, you're likely to get a different medical team than the person that has private insurance. For me, that becomes the basis of a disparity at the very beginning of your clinical journey with cancer. And so that has to stop. And I think when you want to think about cancer staging, shifting, you have to think about the future if you want to do something bold. And it has to be generational. And what that means is that you have to introduce people to these ideas before they're ready to meet cancer stage shifting. At some point, we have to teach young people about clinical trials, and to have a generation that understands what clinical trials mean.
Thank you.
Hear, hear.
Well, I think, is there one more? Okay. We can do one more question. Thank you for your comment.
Oh, hi, I'm Star Robinson Russell again. I'm from Livingstone College. And there was a few things that resonated with me. Of course, your story about being a doctor and then having to become a patient. I am actually in school now working on my doctorate, and it's around teaching healthcare professionals. And just to have a voice as a patient in these discussions with all of my doctors has been just so empowering from a patient perspective. I've just had a lot of different experiences, but what I got up to kind of comment on was in regard to the gentleman that was just speaking about healthcare being different in different places. I have lived and worked in 4 different states. And I received my first, I lived out in Arizona. I'm from originally Indiana, went to school, played basketball at Western Michigan University. So I lived in Michigan for some time, moved to Arizona, and then made my way here to North Carolina. And so when I got my first diagnosis, I was in Indiana. And I was in Anderson, Indiana, which is a small town. And, but we had a brand new cancer unit. And it was brand new. And so, of course, this was my first experience. And so when I tell you the wraparound services that were available to me were amazing, okay? So first off, I had a breast cancer navigator, right? So I'd never really met with a nurse or a doctor initially. I had a navigator. And that's who I met with at first. She scheduled everything for me, done everything for me. I think one of the most daunting things for me initially in my first diagnosis was the fact that I didn't know my way around hospitals. They would give you this information and say you have this appointment, and that was it. And it happens to me here. I get into these hospitals and I don't know where I'm going. I just sit and cry. I would literally sit down and cry. And so my breast cancer navigator from that point on met me in the parking lot of every appointment I ever had, whether I knew where I was going or not. When I went into my first time for my first chemotherapy session, I had a private room because it was brand new. So I wasn't in a communal setting. I had a private room with my own nurse that I met with every single time I went in for treatment. And so when I say I had a private room, I mean I had a room that had a TV, a recliner for myself, a couch and a recliner for my guest, a sink. And so I had no idea that this was done as a community event until I moved here to North Carolina. I had a therapist that I went to see for every treatment, either before or after my treatment. I went to see a psychologist. I met with a financial advisor every month to discuss what was happening in my life. Christmas time, I'm out of work because I just had surgery for 6 months. So let's talk about what you can pay for. In addition, how about, Star, we're going to get you some grants. We're going to get these bills paid for you. the fact that I had all of that, I mean, I could just go on and on. From the finances to my nurse, to my private room, to my nurse navigator, to a team of doctors that sat around that I met with, from a nutritionist to my OBGYN, to all of them were sitting at this table, my surgeons, and so just amazing. And then I moved to North Carolina. And I got my second diagnosis and my third diagnosis here. And I can just tell you that I have been in an uproar, which is how I have gotten this title around here as the troublemaker. Because I walked in there for the first time, I couldn't believe it. I got diagnosed. First off, the lady told me that when I went in for my scans, that she didn't do scans unless there's a reason. What? I've only been out 6 months. You're not going to do a scan for me in 6 months? So I can kind of see where I am. Long story short, I ended up with cancer again 6 months after that. But even still, once I got the second diagnosis and I went in to do this chemo, and I walked in there and it was communal. I was in a room full of people, right? All sitting in these chairs. Now, mind you, this is a very personal event for me. This is no different for me than going to the OBGYN. I don't put my legs in those stirrups in a communal setting. Why would I go through chemotherapy in a communal setting, right? So I'm in there listening to people's whole plan of care. People are throwing up, crying, bleeding, boobs out, you name it, right? So I immediately get up and was like, okay, now I need to go in a private room. I need to, to which they tell me, no, this is better for you, Star. You need to be around people that you can talk to and that no. This is no, that doesn't work for me. I don't want to do this that way, right? I want to go into the room. I want to close the door. If I want to cry, if I want to sleep, if I want to whatever, if I want to talk to my family about whatever, I got to hear personal conversations with their family members about whoever's there. It's just a lot to do. And so I just had no idea. So when I asked them, look, I need a private room, they told me, those rooms we need those every 15 minutes. Right? We get paid off for them. You can't be in there. And so it just was, it was an ordeal when I got here, and it was communal, and it was just, there was no wraparound services. I'm asking, I walk in for my treatment just yesterday. And I'm sorry, are you planning on paying your bill today? As soon as I walk in, what? Like, no, I'm going to leave. Oh, I'm sorry. So I don't really have a question. It was just what resonated. Just about, when you go from one state to another as a patient. Yeah. So no question. Just what resonated with me about, just when I got here, there's no wraparound services. There's nothing. There's nobody to talk to you about your finances. There was nobody to, there was no private rooms. There's, it was just a lot. And so as a cancer patient, just coming from one state to another, you would have thought that there was been some communication. How do we have these new cancer units popping up and there's not the communication coming all the way around? Or when one happens, it should be happening like dominoes everywhere for patients, like myself and for all of us. And so again, I'm sorry, no question. It was a comment.
Thank you for
I don't
sharing
even know where
your
it would go.
story. Unfortunately, you've seen the good and the ugly, but I wanted to follow this by, the Cancer Stage Shifting Initiative. I've had my own experience of going into Flint, and so we have to be able to adapt our solutions depending on which community that you're going into. I know Dr. Puckrin talked about Flint, but my own experience of going into Flint and knowing the prevalence and the water issue that exists, and what you find there is completely different. So the challenges in being able to adapt has to be there. So Flint, for example, has the median income is less than $30,000. And what we know about household families that make less than $30,000, only about 50% of those families have broadband access. So even in terms of designing solutions to do clinical trial diversity, or being able to reach out to these patients through telemedicine and others, now you have to design it around the challenges that exist in that community. So there's certainly challenges, and if you see one community, you've seen one community. So
Yeah. Dr. Pokhran says like 1950s, right? I think you said.
Absolutely.
Or Cuba,
Yeah.
one of the two, right?
Yeah.
Same.
And I know there's some best practices, like there were a company that was experimenting with sending share rides to patients so they can come in and do clinical trials. If you go to Flint, that was the one city I've been to just 68, 70 miles outside of a major city like Detroit. You can't access Uber or Lyft. So think about that. So that's a major hurdle for patients even to be able to get share rides and get to places.
I think it's really just important to recognize that there's work that can be done right now, things that can make these systems better today that will impact lives of people in this room and the people we love and care about. So I think, to echo a lot of what I've been hearing this whole meeting, we just have to keep working and getting stuff done and making progress, because it's a huge family of related problems, and we have to chip away at it. And I think there's a lot of intentionality here, a lot of energy behind it. Thank you all so much for your time, for your attention. Thanks to the panelists here, Mark, Maya, Kayla, Scott. Really appreciate the engagement and the conversation we've been able to have. Please hang tight in this room. We're going to flow into our next event. We need to get these mics off, though, so we're going to exit.
Thanks, Chair. Thank you.
Great. Thank you all for sticking with us. I realize that we are now the only session between you, food, and alcohol. So, promise. Yes. You decide how the order. Thank you for the day and your time with us today. We're going to go into this shorter segment just for the evening around awards and tribute. But first of all, I really, really, really want to say thank you. Even though it's early, I'm confident that I will still be saying thank you tomorrow. Thank you for our CEO Roundtable team that is here. If you could please stand up if you are with the CEO Roundtable, Project DataSphere, please stand up. It's a full team effort, and really, really, really thank you so much because without any of those individuals, we would not be here and having such a wonderful evening and time together. So I would actually just kind of like to roll us through the next 30 minutes here. I'm going to do that in a 30-second piece, so that way we'll just kind of keep trucking right on through. We're going to first hear from Joya Delgado Harris. Joya is the executive director of the Gold Standard, the CEO Cancer Gold Standard. She'll be sharing the Gold Standard accreditation, and she'll be coming to the podium to do that. After that, Dr. Otis Brawley will join us. Dr. Brawley is a professor at Johns Hopkins University, but he's also the Bloomberg Distinguished Fellow. I often refer to Dr. Brawley as America's oncologist, and you will hear more from him tomorrow. But Dr. Brawley will be paying tribute to Dr. Edith Mitchell, whom we lost this year. Mr. Tim Gable, President and CEO of RTI. Frequently, people get promotions whenever I speak, so don't be surprised. And then we'll be hearing from him as well as a tribute for Mr. Ingram, Mr. Robert A. Ingram, and then Mr. James Satori, who is CEO and founder of Brand Institute. And then I'll be back up here to share with you our spirit of health. Joya, please join.
Thanks, Mary Liz. I'm glad I'm not last in standing between you and alcohol and food. But just wanted to announce our newest Gold Standard accredited companies or schools. We're super excited. We haven't done this since November 2022, so I wanted to share with you the companies that have received, and they're right there, so you can see them yourselves. If you're from these companies or schools, please stand so we just can acknowledge you. But Cardinal Health, Caribbean University, yes, Dillard University, Medgar Evers College, wonderful. Merck and Company, is that the whole room? Yes. Thank you. Southern University Law Center, Y'all been standing the whole time. I did say please stand. Listen, if you did it, you deserve to stand the whole time. And Winston-Salem State University. Wonderful. And so some of these companies here, we want to acknowledge everybody. They received recognition at our last, at the annual meeting last time, but please read them. And if anyone is here from these organizations or schools, please stand as well. Alphanumeric is here. Jasper Health is here. Okay. I didn't rehearse too hot, but here's the deal. It is quite an accomplishment, and we really appreciate it. It is a tool that can be so useful in many ways, and it really demonstrates the commitment to the culture of health of an organization, and we appreciate the time it takes to complete it, the time it takes to implement it. And since I'm saying that, I should acknowledge the people on our Health and Wellbeing Council who are here, like Marcelo Targino. And who else is here from our Health and Wellbeing Council? Dr. Brawley is here, and he's next. See how I did that? But thank you, everybody.
For those of you who were here last year, you will remember Edith Mitchell, Dr. Edith Mitchell was with us. Dr. Mitchell unfortunately died in mid-January. Edith was a friend of my family's for almost 50 years. I knew her for well over 40. She was 76 years old when she died. She was a remarkable person. Most of us know her as a gastrointestinal oncologist. We know her as a leader of the Eastern Cooperative Oncology Group, which is one of the major National Cancer Institute clinical trials groups. We know her as a leader at the Kimmel Cancer Center at Jefferson University and as a professor there. She was a member of the President's Cancer Panel appointed by President Trump in 2019. She was president of the National Medical Association. I, partly because of our family friendship and partly because I was a public health service officer, always addressed her as General Mitchell, because General Mitchell was the first female physician, black or white, as she would like to say, to become a general in the United States Air Force, Air Force Reserve, or Air National Guard. Indeed, many people didn't know that side of General Mitchell. She was a flight surgeon. She was a jet pilot. I actually have a picture of her it was in the back seat, but it was still in an F-15. She grew up in Brownsville, Tennessee, and she saw segregation there. She also saw the importance of role models and frequently reminded the rest of us of the importance of role models. She went to Tennessee State University with my sister, and then she went to the Medical College of Virginia and graduated from there in 1971. Medical College of Virginia, when she went there, was a very segregated hospital. There were times when they wouldn't allow the one black medical student into the white hospital. She remembered that, and she also remembered a fellow named Walter Lawrence. Walter Lawrence was a very tall white man who became a role model, almost got her to become a surgeon. Walter Lawrence was, by the way, well known for his civil rights work. Walter Lawrence and C. Everett Koop were at the National Medical Association meeting in 1950, and everybody was wondering, where the hell is Drew? Charles Drew, the black surgeon who invented the blood transfusion, or the plasma transfusion, died in an automobile accident driving to the National Medical Association meeting in Tuskegee in 1950, and he was overdue. But Walter Lawrence was a white doctor who was at the Black National Medical Association meeting wondering where Drew was. Walter Lawrence became a role model for Edith. Edith graduated from the Medical College of Virginia and did a residency in Nashville, a fellowship in hematology and oncology at Georgetown. She went on active duty with the Air Force for a time, served at the University of Missouri as a physician there on faculty. Later went to Jefferson Medical College in Philadelphia, which is where she worked until she died. Her husband, by the way, Colonel Delmar Mitchell, was an Air Force pilot and was actually the pilot for Air Force One for several of the Reagan years. They had 2 children, Dale and Deanna, and they have 4 grandkids. Delmar died 2 years ago, and we lost Edith, as I said, in the middle of January. She was flying back from the ASCO, the American Society for Clinical Oncology GI meeting, which was in San Francisco. She was there, of course, to better cancer treatment. She flew a red eye. I actually talked to her that Friday night, and she was going to the airport, and she flew a red eye, and unfortunately, after the plane landed, she collapsed and died that next morning. And so, can we have a moment of silence for General Dr. Professor Edith Mitchell? Thank you.
Bob Ingram. I'm Tim Gable. I'm the president and CEO of RTI International. I'm not Randy Trice, the CEO of Alphanumeric, who was supposed to be up here starting this off. But Randy had a sudden conflict and couldn't be here and asked me to stand in. And he asked that I tell you a story, to tell you Randy's story, not my story, about Bob. So those of you that know Randy and have had some interactions with him know he is a tried and true Texan, a Texas A&M Aggie. And back in 2017, when Randy took over the role of CEO of Alphanumeric, and after all those years in Texas, moved to North Carolina, the first phone call that he got was from Bob Ingram. And Bob had heard of his arrival in the Triangle. Bob was reaching out to him, welcoming him, offering his support to him, telling him, let me introduce you around, let me get you acquainted, doing what Bob did. That was Bob being Bob, right? And, but he did another thing. And Bob said, now there's a couple things I need to get you involved with once you're here. And those of you that know Bob and those of you that know Randy, I'm sure could imagine what that conversation was like. But Bob said, there's a couple things that are important here that you need to get involved with. One of them is the CEO Roundtable on Cancer. And when I heard that story, it made me smile because I could visualize, having had the privilege of knowing Bob, just what that felt like. And, I'm sure Randy couldn't imagine a way to say no after such a gracious thing. But, Bob did what Bob does, or Bob did what Bob did. And that is bring the circle bigger, bring somebody in to help make an impact. And so I wanted to start my comments here just acknowledging on Randy's behalf what a remarkable person Bob was. I can't channel Randy's Texas accent, but I hope that that little story made you happy. So I wanted to say just a couple words about my relationship and experience with Bob. Bob served on RTI's board of directors for 12 years. And I've been at RTI a long time. I remember when Bob joined our board, I was not interacting with the board members at that time in my role, but we couldn't believe what a major coup that was, that somebody of that stature was joining the RTI board. He served on our board from 2010 to 2022, 12 years, and served on and then also chaired our Compensation and Strategic Talent Committee of the board. Remarkable board member. He was, I remember him telling me, he said, you know, I've always had a philosophy, 12 years on a board is enough, okay? Because if the company still thinks they need you 12 years later and you're adding value, either they're doing a bad job and you want out, or there's got to be somebody that's learned more and can add more value. You've given them about what you want. So Bob let us know he was stepping down from our board in 2022. And sadly, Bob's passing occurred not that long after he stepped down from our board. So what we as an organization have decided to do, and I'm wanting to make all of you aware of this, is we worked with the local chapter here in the Triangle of the National Association for Corporate Directors, NACD. Any of you that know that organization know that it has a mission to ensure that corporate governance is strong and successful. And all of the thinking about partnership that we've talked about here, I think that's an important component. So what we decided to do is fund a fellowship to that Triangle chapter, named in Bob's honor. And it is a fellowship, but it's a fellowship with a particular angle to try to help underrepresented women and minorities to find their way onto boards. And we felt like, knowing what a great board member Bob was for us, this was a really fitting tribute to him. So I want you to be aware of the Robert A. Ingram Fellowship for Excellence in Corporate Governance. This is to support the professional education experience of emerging leaders as they traverse onto corporate boards. And the fellowship is being managed by the NACD chapter, but it's really to identify those high potential people that may not otherwise have an opportunity to make it into that path. And those of you, again, who knew Bob and can appreciate Bob, knowing what a mentor he was, knowing how many women Bob sponsored and really brought along in their careers and so forth, this was our way of trying to extend our gratitude to him and help build a legacy. Now, I'm not Bob, and I'm not as good as Bob of doing what Bob did, but what I want to let you know, and I would welcome anybody that wants to give me your card, we want this to be a sustainable fellowship. The chapter needs it to be a sustainable fellowship. So anybody that had a relationship with Bob, has any kind of interest in this at all, I hope you'll talk to me, because what we want to do is make this a lasting legacy. And I appreciate, Mary Liz, the opportunity to tell folks about this. And the last story I'll give you, when I became the CEO of RTI 2 years ago, of course, you know, you're sitting with somebody of Bob's stature. And I said, what advice do you have? I mean, you're this amazing person. I mean, I'm a brand new CEO. What do you think? And he said, Tim, you be you. Don't try to be the guy that was. Don't try to be what you think the right person is. You be you. And if you do that, you'll be fine. And I'll tell you, I was blessed to have Bob as a mentor and a colleague. And it makes me smile every time I remember him telling me that. And so I hope it makes you smile too. Thanks, Mary Liz.
I brought a script. For knowing Mr. Ingram, wow, it goes way back, 40 years. 40 years of him taking me under his wings. I was a nobody. Boy, it's rough. It is very rough because he touched me in so many different ways as he touched probably many of you. When you think through, I hope you, I have a script to give him justice. And also I wordsmithed, and I'm in the business of wordsmithing, but I couldn't find as many wordsmiths. Boy, I ran out in the dictionary. But I want to first of all thank the SAS group and Mr. Goodnight, Dr. Goodnight, excuse me, for hosting this. This is amazing. The 6-star treatment we're getting here is unlike anything I was ever trained. I was in hotel restaurant management in my earlier days, so I hope it doesn't lose any credibility here in naming drugs. But at the same time, they've been wonderful. And I want to thank also Mary Elizabeth, thank you and your whole group at CEO Roundtable. We're a new one. We just got accepted as a member in January, and we're so proud to be here. This elite group is unlike anything I've ever seen. And I've named a lot of products and been to FDA and EMA and Health Canada and everywhere. But this group is amazing, very, very special. Never lose sight of that. And I know Mr. Ingram wouldn't. And I'm just going to go through my script, so I apologize. Boy, this is as bad as it. It's with great respect and admiration that I deliver this afternoon's tribute for Bob Ingram, known as Bob to everybody. I used Mr. Ingram out of respect. He always chuckled. He said, "Jim, you're one of the few that actually address me, as Mr. Ingram." I said, "I'm sorry, but that's out of total respect to you." I knew him for 40 years. We go way back. And we first met at Glaxo Wellcome, which probably some of you might have even been there, on a naming initiative. Wow. It's impossible to forget a couple things, his iconic style. Wow. Elegance, passion. And as you heard here and also in the past, January, his innate ability to unite and motivate people. Just think if we could all do that. And that's here. We have the ability. We have definitely the forum. We just got to do it. This deep-rooted character quality, I personally experienced in the development of their first, wow, this goes way back, first-in-class antiemetic product, Zofran. And Dr. Murphy, is Dr. Murphy here by chance? He mentioned at the eulogy for Mr. Ingram. And he said, "I'll remember you, Jim, because you were there in that room." And Mr. Ingram always talked about what you did and what he did. Mr. Ingram did it. He really, really did so much for this industry and for all of us. And for those of you who didn't know him, boy, you only wish you could. Wow. Touched a lot of people. When Mr. Ingram entered the room, boy, his first time he truly had a distinguished persona, all about himself. Think of how he entered into your lives and into your conference rooms. Clean cut, handsome, humble, respectful, always respectful, in control, but no way rude. He was a walking fashion statement. He wore those Brioni suits. Wow, wish I could afford them. His Brioni brand, impeccable style, charisma, and grace. He reminded me of Cary Grant, the way he carried himself, the way he dressed. He truly was a model. Mr. Ingram loved to dress for success. I'm not, oh, okay. I thought I was doing something wrong. Always professional, and so well put together, from his infamous French cuffs, which, see, and to his pocket squares. Yeah, mine are sewed in. I can't even use it for up here today. It's the only way. His pocket squares never, ever altered. I don't know, and he didn't sew them in like I did. His flawless appearance, oh man, reflected the pride he took in his work and everyone else's work. He was able to motivate people to be best in class. Just think what he did to a lot of you. If he reached out and touched your hearts and your business like he did with me, wow, you're one lucky group. You're one lucky person. When I started my company in 1993, Mr. Ingram was so kind to write a testimonial recommendation that gave immediate credibility to what my work was in the past as well as the company. He did it for so many people. He really, really touched a lot of people. I remember in 2001, Mr. Ingram and I spoke. We were crossing the halls in a project, and he expressed his excitement and honor to be appointed by the late President George H.W. Bush as chairman of the CEO Roundtable, wow, on cancer, where he brought together many of you here, and I see you all smiling and nodding your heads. There are a lot of you that he touched in a positive way. And wow. And he touched him to have a common cause, for everybody to work together to eliminate and eradicate cancer. And that's what we're here for, all of us. There's so many specialties in this room and in this group, the CEO Roundtable, with government, with nonprofits, with academics, with also, more importantly, just overall good, solid people in stock. As he said, Jim, I'd rather deal with people that have good stock than good, that's being really experienced. You know, he doesn't need, it's like any great team, whether it be Duke, North Carolina. It takes a team to win. And it's going to take a team to win here, especially to overcome cancer. And that's what this group is made of. I hope I'm not going too long. A couple pages more, I'll be done. Yeah, Mr. Ingram was a great friend. Mentor, you know. Yeah, you said, well, Jim, why don't you write a script? Thank you. Why don't you write a script? You won't do this. But I did this also, this funeral, and people almost kicked me out. Poor Bob was a great friend and mentor. I came like Bob from a meager background, and for someone to reach out who didn't know me, I was not part of the family, and maybe part of his family. It's pretty special. He was selfless in everything he did. He just worried about you. And that's why I continue to hear all the time. He always, the underdog. He really worked for the underdog. Despite coming from meager beginnings, and boy, Mr. Ingram overcame and accomplished so much in his days. He earned and deserved everything he accomplished, and he was a true inspiration to others. He went through life with many successful beliefs. One that helped me with his old-fashioned thinking was through hard work. For he truly believed hard work works. He used to tell me that all the time. He would come to Miami, where we're based. His grandson and granddaughter, Vincent and Olivia, went to school, University of Miami. And he used to come down all the time, would have a bite to eat. And he said, Jim, work hard, because hard work works. And it's true. And that's what he believed in. He was an unselfish person who gave back so much to the healthcare industry by promoting equal business opportunities for women. How many ladies here as well around the world that I worked on projects, and they all said, those ones especially starting businesses, that Robert Ingram was one who helped them, truly helped them. Wow, and also all people of all nationalities. He really helped everyone and lent his time to that. He recognized the importance of supporting others and was always willing to go out of his way to help those in need. That was one of his real key traits. He would go out of his way to help other people. He represented our country in the world with his expertise and passion for eradicating global diseases, and many of you know that are now the foundation of our medical community. This applied to his work in oncology as well as many other therapeutic areas. And it even extended into the 2020 that we talked to today, COVID-19 pandemic. He was part of that. And Robert's legacy will live on, through his loving wife, Jeannie, the Ingram family. Wow. And all the lives he touched here and around the world. I'm just really grateful for the time I had with him.
So yes, the unique thing about both Mr. Ingram and Dr. Mitchell is that they both served on the President's Cancer Panel at the exact same time. And they were both here with us, along with actually Dr. Williams. We had each President Cancer Panel member here with us in 2022. Time changes. So make sure that whenever you're talking to people that matter to you, spend time with them. Whenever Bob was here with us in 2022, he was in a clinical trial at the time. He had just had treatment that week. And he called me, he said, "Mary Liz, I won't let you down." He said, "I'll be there." We made some arrangements and he made it through the evening. He fell asleep, I think, while I was talking, but I told him I'd forgive him for that. But actually, Mr. Ingram is actually one of the reasons why I'm here. He doesn't call you often, but whenever he does, you definitely answer the phone. And I received a text from him. It's in October of 2019, and he said, "Do you have a minute?" It's 9 o'clock at night. It's like, "Of course. When would you like to talk?" "Now." "Oh, okay." And he asked me if I would be interested in coming over to the round table. And I said, "You asked me? Then yes, of course." We had a history together around cancer. And I knew Mr. Ingram differently from a lot of people. I didn't necessarily know him from the corner office. I knew him from the community. I knew him for what he did in the community. It went far beyond the corner office. He always put patient first, and you heard that a lot here today, patient first mentality. That was always his question around his table at GSK. How does this help the patient? Can they afford the drug? If we create this that saves his life, can they afford it? So let that be our beacon of how we move forward, patient first, in the spirit of Bob. And out of that spirit of Bob, we've actually renamed our Spirit of Health Award to more amplify his legacy on health. And it will now go forward, as voted upon by the CEO Roundtable Board of Directors, as the Robert A. Ingram Spirit of Health Award. So now I'm pleased to share the recipient of that Spirit of Health Award. I want to give you a little bit of description of it. It was created in 2021, so a relatively new award for our enterprise, to focus attention on the health of those disproportionately affected by cancer, and the difference that one person can make through their leadership, vision, passion, and pure drive to connect people and institutions to eliminate disparities. The award recognizes individuals and companies who have worked in extraordinary and tireless ways to elevate communities of health, accelerate health equity, bridge the gap of the cancer burden, expand cancer prevention and health education, and to ensure access to care, and in doing so, they have changed the course of lives. This year, our recipient of this now recently renamed award, the Robert A. Ingram Spirit of Health Award, is Gail Stevens and SAS. Yes. Do you want to say a few words?
I'll say just a few because I know I'm standing between you guys and your dinner. But I do want to say how much we at SAS appreciate this award, and it is one of our core values, and I appreciate working for a company like this that allows us to care so much about research in cancer and treatment for cancer, and just finding the bits and pieces that we can do as a company to help the journey. So, and me personally, you know, I have family members I've lost to cancer. That's how I originally got involved. And I just want to say, and I'm going to say this without crying, I call Bob a friend too. And let me just tell you one thing about Bob, and then I promise I'll move on. But Bob was one of these people who I always felt like when he walked in the room, he was the most important person there. He was the most inspirational person. He was the person that you looked to and you thought, yeah, Bob will get it done. When Bob's here, Bob organizes everything and it's going to be great. But when he talked to you, somehow the spotlight seemed to come off of him and onto you, and you felt like the only person in the room. And he was just that great. When you were talking about some of the things about Bob, I remember going to the Christmas party where Bob spent a lot of time talking to me and offered to let me drive his fancy cars. And I was thinking, I really felt like his friend. I mean, it was awesome. And so I'm especially proud to get this award just because Bob's name is on it. So, but all that to say, you know, thank you so much. And thank you on behalf of SAS. And we're going to continue to do whatever we can and in whatever capacity we can to help the fight against cancer.
You can stay right here. Okay. So that concludes our programming part of the evening. And Bob Ingram and Dr. Mitchell would say, please raise a glass and eat dessert. So please join us downstairs for our reception, our dinner, and there will be no other programming for the evening. It's completely social and networking, so please enjoy your time here, and we look forward to spending time with you downstairs. Thanks so much.